Yeah, Dr. Prashant, you can start.
Yes, thank you. Good afternoon, doctors. Welcome you to this webinar on carbetocin in action. Dr. Meenakshi, I'm starting.
Yeah.
Yeah. Good afternoon, doctors. Welcome you to this webinar on carbetocin in action, sponsored by HITRO. HITRO snapshot, you have 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. HITRO has 21,000 employees globally and amongst the largest manufacturers of ARV, APIs, and FDFs in the world. HITRO has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. HITRO Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties, pioneering in quality and innovation, and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Carbetocin in Action. Doctors, we all know that carbetocin is a drug which is used for prophylaxis of PPH, and PPH is a condition which is potentially could be disastrous. Although there are a lot of papers on PPH and the requirement of rapid action and onset of action with carbetocin, we always require our doctor's own experience to throw light on carbetocin. For that, today we have got Dr. Meenakshi Misra to share her experience on use of carbetocin in PPH prophylaxis. Dr. Meenakshi Misra, MBBS DGO ICMH, founder member secretary Dr. Jha Welfare Society, Foxy certification on HPV vaccination, Foxy certificate master training, say no to violence, organize free camp for cervical cancer awareness, screening and vaccination, awareness on menstrual hygiene, and AUB in many schools. Madam is life member Foxy, IMA, ARSI, NAV, SFWI, ISCCP, and IFCPC. Joint Secretary UP NHA 2018-2019. President UPNHA Hathras, Health Icon Award, UPNHA 2018. Madam, welcome to this webinar, and we are waiting to hear about your experience on carbetocin. Over to you, madam.
Okay. Thank you, Dr. Prashant, for giving such a wonderful introduction. Thank you so much. So, as we all know that what is postpartum hemorrhage, PPS. Can you move the slide? Yes. So, as we all know, I'll describe a few points about PPH so that we can go through what happens and what is mild, moderate, and severe PPH. Then we will discuss the role of carbetocin in PPH cases. So PPH is the loss of at least 500 ml blood following vaginal delivery and 1000 ml following cesarean section. As you can see in the slide, this is the normal the slide one is of normal postpartum patient with contracted uterus preventing hemorrhage. And in the slide 2, you can see uterine atony allows hemorrhage to flow into the uterus. So PPH is common and can occur even in women who are not at risk. PPH is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all maternal deaths globally. Next, please. So, postpartum hemorrhage, it's unfortunate, but it's common. It can happen in normal individual also. We are not expecting PPH in a normal individual, but we can have PPH in a normal coming delivery. Like we are expecting that this is a normal patient and suddenly PPH occurs. So maternity MMR in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. So 14 million women suffer from PPH. Incidence of PPH is reported as 2% to 4% after vaginal delivery and 6% after cesarean section. PPH incidence in India is 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India and 2/3 of these attribute to PPH. India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. So it's very common. So what is the etiology of postpartum hemorrhage? We can remember 4 T's: tone, thrombin, trauma, and tissue. So what is tone? Tone is uterine atony. which is inability of the uterus to contract, which may lead to continuous bleeding, which is very common. Which I think in my experience, I come across around 80% or 70% of atonic uterus, PPS due to atonic uterus. And second one is thrombin, like coagulopathies, failure in clotting. Trauma, any trauma, vaginal, or while you are doing cesarean section, your angles distended. You can have trauma, injury, uterine trauma, injury to the birth canal, rupture, uterine inversion, and laceration. You can find any one of them. And the fourth one is tissue. Any tissue which like retention of placenta, remain placental membranes, attached placental membranes. Normally they are removed by manually or by putting some gauze or something. Clots and abnormal placenta. Next, please. So, what is the clinical findings in PPH? So, a quick revision. When we come across with the patient of PPH, we normally tend to see abdominal tenderness and the size of the uterus. Sometimes the size of the uterus extend up to the umbilicus. Circulatory collapse, sudden fall of BP, pulse tachycardia, increasing abdominal girth, as I have mentioned earlier, loss of uterine contractions, maternal tachycardia, loss of uterine contractions, the uterus becomes flabby. Like you can't feel the upper margin of the uterus, and it becomes flabby. Maternal tachycardia, obviously the hypotension occurs, the maternal tachycardia happens, then the vaginal bleeding. So the clinical findings in PPH is, we can tabulate in the form of mild, moderate, and severe, depending upon the degree of shock. So normally what happens, suppose the blood loss is around 500 to 1000 ml, it can be compensatory, like 10 to 15%. When PPH is mild, that amount of blood we can measure, we can see the amount of blood is around 1000 to 1500 ml, 15 to 25%. And in moderate, 1500 to 2000 ml, and in severe, 2000 to 3000 ml. What happens in mild cases, or when we see the amount of bleeding is just 500 to 1000 ml, not significant blood pressure changes occur. Symptoms and signs might be palpitations, dizziness, tachycardia. Just that. It can be managed by giving RL or colloids also. And in mild cases, we can find slight fall of blood pressure up to 80 to 100. Weakness, patient feels weakness, sweating, and tachycardia. Sweating is very important sign. When you see all these things, you have to be very, very careful. And second one is moderate, 1500, in which 1500 to 2000 ml blood loss occurs. In this condition, marked fall in blood pressure at 70 to 80 mm of Hg, and patient feels restlessness, pallor, and oliguria. And in severe cases, in which 2000 to 3000 ml blood loss occurs, profound fall in blood pressure, like 50 to 70 mm of Hg, and sudden collapse of the patient, air hunger, and anemia. So these are the points which has to be taken in mind. If a patient is giving these signs and symptoms, we have to be very careful. Next, please. So how we diagnose postpartum hemorrhage? A quick initial evaluation, rapid assessment of patient status, presence of tachycardia and hypertension, assessment of vital signs and blood loss. Examination at the time of hemorrhage, assessment of entire genital tract. When we are doing normal delivery, I normally have this practice to examine if the PPS is not occurring. Still, I always examine cervical region and the perineum also. If they most of the time I found laceration, and hematoma, vaginal hematoma. So this has to be kept in mind. Assessment of the entire genital tract for lacerations, hematomas, or signs of uterine rupture. Manual examination for retained placenta tissue. Assessment with bedside ultrasound to check if the uterus is non-contracted. Evaluation of uterus to check for uterine inversion also. So what are the laboratory assessment? Complete blood count to check hemoglobin, hematocrit, and platelet. Coagulation studies and assessment of fibrinogen. This is very important. Next, please. So, how will you approach towards postpartum hemorrhage? In poor tone patient, in poor uterine tone patients, clinical finding will be abdominal palpitation. Uterus will be uterus will be relaxed, boggy, and soft. And you may maybe felt above the umbilical, may feel the uterus fundus above the umbilicus if uterus filled with blood and clots. So investigation, full blood count, coagulation profile, urea and electrolytes. If patient is not responsive to fluid and blood replacement, abdominal ultrasound to exclude uterine rupture or intraperitoneal bleeding. I want previous one, please. I want previous. Yeah, this one. So how will you manage? Management is uterotonics, oxytocins, and oxytocics, and prostaglandins, and ergot alkaloids. We can put uterine balloon tamponade if a patient gives time. Hemostasis algorithm. See main article for recommended stepwise surgical measures when medical treatment fails. Tear or trauma. Clinical findings would be bleeding from area of trauma with within genital tract, uterine rupture, extension of uterine angles also, tears during cesarean section. Extragenital causes might be such as subscapular liver rupture or rupture of ovarian or splenic vessels also. Investigations, inspection during cesarean section by externalization. And by ultrasound, we help identify the free fluid in patient with uterine rupture. How will you manage? Management is repair of identified genital tract trauma. Pelvic arterial embolization could be also be done. And in retained tissue, clinical findings would be retained placenta and membranes. Identify those by manual examination and do it accordingly. What are the investigation? Investigation should be done under anesthesia. Management is manual removal of placenta or any placental membranes or any clots. In coagulopathy, clinical findings would be continuous bleeding, but although the uterus is contracted, but the bleeding is coming out continuously. What are the investigations? Urea and electrolytes, full blood counts, coagulation profile. And management is medical immediate replacement of blood and coagulation factors and platelets. Surgical only with trauma or atonic hemorrhage, unresponsive to medical management. Next, please. Rationale for development of carbetocin in new heat stable formulation. So carbetocin is available in room temperature RTS, room temperature stable formulation and convenient vial presentation. This has an advantage over oxytocin. Oxytocin or ergot alkaloid should be kept in refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 to 8 degrees centigrade, but now it can be kept at it is kept at the room temperature. Resources poor countries do not always have cold chain transport and storage capabilities. Need for refrigeration is stable. This is stable at room temperature. Carbetocin is stable at room temperature. Half shelf life is 24 months at 30 degrees centigrade and 75% humidity. Avoids need for cold chain storage and logistics. Is provided in vial. This has an advantage. Next, please. The use of uterotonic agents, time of administration. When to use these uterotonics? So the molecules are, as you can see from the chart, molecules are oxytocins, carbetocins, ergometrin, symptometrin, and misoprostol. And how and when it should be used. time of administration should be at the crowning of baby's head. This is the best time. I feel practically this is the best time period. We should give this any oxytocin, like oxytocin, carbetocin, whatever you like. At the time of delivery of anti-shoulder, at the end of second stage of labor, following the delivery of placenta. These are the 4 points when we can give, when we can administer these molecules. What is the prophylactic use? Prevention of PPS, active management of third stage of labor. Therapeutic uses, management of PPH. Next, please. Currently available uterotonics in India are these are the molecules, 4 molecules which are available in India: oxytocins, misoprostol, ergometrin, and carboprost. These are the 5th one is carbetocin. So we have used previously we have used carboprost in PPH and oxytocins combination, misoprostol and ergometrin combination, depending upon the condition of the patient. So doses and route of administration of oxytocin is 10 international unit intramuscular, 5 international unit IV diluted to 5 ml over 1 to 2 minutes, and it should be given slowly. 20 units in 500 ml NS or RL infusion at the rate of 150 ml per hour. Duration of action is onset 2 to 3 minutes, lasts up to 15 to 20 minutes. None or minimal side effect. And what are the precautions? Direct IV oxytocin contraindicated in cases of cardiovascular failure and heart disease. Misoprostol, regarding misoprostol, it should be given in PPH cases 600 microgram orally, sublingually, or per rectal. I usually prefer per rectal. And its onset of action is 3 to 5 minutes. Peak comes around 20 to 30 minutes, and it lasts up to 75 minutes. But there are some side effects like shivering and slight rise in temperature also, but no contraindications. Ergometrin, 0.2 milligram intramuscular, onset is 2 to 7 minutes, lasts up to 2 to 4 hours, may increase risk of retained placenta, nausea, vomiting, headache, and hypertension. Sometimes I practically notice in few cases, some patient can have arrhythmia also. And in which cases we have to be taken precaution. We have to take precaution in hypertensive patients, heart disease patient, RS negative mothers. Carboprost, this is its dose is around 250 microgram intramuscular. Onset is 1 to 2 minutes. It lasts up to 15 to 20 minutes. But there are side effects like vomiting, diarrhea, and the field become messy just because of a stool, bronchospasm in some patients. So the precaution is to avoid carboprost in bronchial asthma patient. Next, please. Concerned with available uterotonics. So the oxytocins, it requires, these are the few points why we should give carbetocin as a first line therapy in active management of PPH. Because oxytocin requires special storage condition like 2 to 8 degrees centigrade. Ergometrin requires special storage, the 2 to 8 degrees centigrade. Misoprostol less effective in preventing PPS. Alone, it can't manage PPH. Carboprost, yes, definitely this can manage PPS, but some side effects are there. It requires a special storage like 2 to 8 degrees centigrade. Multiple doses in oxytocin, multiple dose resin. Short acting multiple doses may be required in oxytocin. Overdose or prolonged use can cause water intoxication also. Prolonged use can itself lead to uterine atony. And in ergometrin, it is associated with significant increase in side effects like nausea, vomiting, and hypertension. Needs to be avoided in SDP, including chronic hypertension. While in misoprostol, more side effects such as shivering, pyrexia can occur, associated with the higher risk of severe PPH and increased use of additional uterotonic. Use with caution in patient with cardiovascular diseases. While in carboprost, associated with side effects like vomiting, diarrhea, and bronchospasm, needs to be avoided in patient with asthma or significant renal, hepatic, and cardiac diseases. Next, please. So the new molecule, carbetocin, it's drug, synthetic, long-acting, and analog of oxytocin also. Therapeutic indication is prevention of PPH due to uterine atomy. And the posology and the administration, one vial contains 100 microgram of carbetocin in 1 ml solution for injection. Next, please. So carbetocin, what are the, when we compare carbetocin with oxytocin, because oxytocin is, it is cost effective also. And carbetocin is a bit costly, but when we have severe PPH, we have to depend on carbetocin. This is my experience. So what are the drawbacks of oxytocin? Antidiuretic effects, water intoxications, multiple dosing regime, short acting repeat doses might be required, failure of PPH prophylaxis, stability and quality issues are also there. Next, please. Next, please. So, carbetocin compared to the oxygen, use of carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics for those who underwent cesarean section. Carbetocin was associated with reduced need for uterine massage following both cesarean and vaginal. Compared to symptomatin, combination of ergometrin and oxytocin, carbetocin showed a lower mean blood loss in women. Risk of adverse effects such as nausea, vomiting was significantly lower in carbetocin. Incidence of postpartum hypertension was also significantly lower in carbetocin. Next, please. So this is the comparison of carbetocin versus oxytocin. Carbetocin was as effective as oxytocin in prevention of PPH. Carbetocin showed lesser mean blood loss in some studies. Carbetocin enhanced early postpartum uterine involution in some studies. Carbetocin showed fewer women requiring additional uterotonics in some studies. Carbetocin showed fewer women requiring uterine massage in some studies. Carbetocin showed lower blood transfusion as compared to the other. Carbetocin showed lower incidence of postpartum anemia in some studies. Sorry for pause. Yes. Now the comparison of carbetocin versus symptomatrin. I normally don't use this combination. Carbetocin showed lesser mean blood loss as comparison to symptomatrin, and additional uterotonics is lesser used, is not used even, and incidence of postpartum anemia is also lower incidence of postpartum anemia in while you is using carbetocin, and carbetocin was also associated with lesser incidence of nausea, vomiting, and symptomatrin was associated with increase in systolic and diastolic blood pressure. So this had advantage over symptomatrin also. Next, please. Now the carbetocin with misoprostol, I don't depend on misoprostol alone. So obviously, when you are having, when a patient is having profuse bleeding or passing into the, even into the mild PPH, when I expect that this patient is going to bleed, I always give carbetocin as a first line of treatment. Next, please. So according to the Cochrane library, 3 most effective drugs for prevention of PPS more or equal to 500 ml were ergometrin and oxytocin combination, carbetocin and misoprostol plus oxytocin combination. These were more effective at preventing PPS more than 500 ml compared with oxytocin, the current standard. 2 combination drugs, however, are associated with significant side effects that women might find disturbing compared with oxytocin. Carbetocin may have some additional benefits compared with oxytocin and appears to be without an increase in side effects. Next, please. So this is according to WHO. This is summary of treatment effects of uterotonics agents versus reference agent is oxytocin on beneficial outcomes. So as you can see from the chart, carbetocin is probably superior in controlling PPH more or less, more and equal to 500 ml. It is superior to the additional uterotonics also, and it is superior in minimizing blood loss also, and it is superior in change in hemoglobin also. And as you can see in prostaglandin, additional uterotonic, possibly this is also superior. And in oxytocin plus argometin, symptomatic. PPH, okay, it is also superior as when we compare, and additional uterotonics, possibly it is also superior. And misoprostol, yes, PPH is possibly superior, and in additional uterotonics, yes, probably superior, and in blood loss, probably superior, and change in hemoglobin, possibly superior. So previously we used to give a combination of two drugs like oxytocin plus misoprostol, depending upon the condition of the patient. But nowadays, I depend on carbetocin much as compared to the other molecules. Next, please. So summary from analysis of data and literature of carbetocin. It's long-acting, does not require prolonged IV infusion. It's very simple, administered via single IV injections with no need for repeated injections also. Well-established dose, validated for prevention of PPH, lower affinity to vasopressin B2 receptor compared with oxytocin. Possibly less blood loss and requirement of additional oxytocin. Stable at room temperature. Next, please. So, the characteristic of this molecule, carbetocin, its onset of action is within 2 minutes. Half-life is 33 minutes while you are giving IV, and when you are giving IM, it is 55 minutes. And the duration of action is 60 minutes, or it can be more. While when you are giving IV, and when you are giving IM, it could be around 1.5 hours, around 119 minutes. And doses and mode of administration is 100 microgram administered IV slowly over a period of 1 minute or intramuscular, and must only be administered after delivery of the infant, and as soon as possible after delivery, preferably before the delivery, and it is single use. No further doses should be administered. And storage, you can store this drug in room temperature less than or equal to 30 degrees centigrade and 75% relative humidity. Next, please. Next, please. Yes, next, please. Yes, carbetocin non-inferior to oxytocin. This tabulation shows that blood loss of more or equal to 500 ml or the use of additional uterotonic efficacy is 14.5%, while in oxytocin 40.4%. Blood loss more or less, more or equal to 1000 ml is 1 point efficacy is 1.51%, while in oxytocin 1.45%. And the safety is at least one unanticipated AE, 4.9%, and while in oxytocin, 4.7%. At least one serious AE, 0.7% and 0.6%. Next, please. So according to the Cochrane review, carbetocin for women who undergo a cesarean section, this drug resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptomatic in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next, please. Next, please. So these are the guidelines according to WHO, according to the SOGC, Canada, and RANZ, ZCOG, New Zealand, PIGO. All the guidelines for PPS prophylaxis all are mentioning in this chart is carbetocin, 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 and carbetocin. So definitely this is a good drug, and it is the doctor's choice and the patient's condition what drug or what molecule has to be given. Next, please. So my experience with carbetocin is, yes, definitely it's superior, no doubt about it. And it is manageable also. You don't need to keep these molecules in the refrigerator. And it has less side effect, in my opinion. I have a few cases which I have mentioned here. This is a high-risk pregnancy, multigravida, G3P1L1A1, twin pregnancy. Her gestation age was 34 weeks, previously delivered normally. So on ultrasound, one baby was cephalic and another baby was breech. It weighing around 2.2 kg and 2.1 kg. On PV examination, os was 6 centimeter dilated, delivered normally, both delivered normally, one cephalic and one breech. After delivering second baby, carbetocin was given slow IV, and the placenta was expelled spontaneously. Bleeding was normal and uterus was well contracted, although the patient was kept under observation for at least 2 hours, which is the golden period. It has to be kept in mind that whenever you are dealing with the high risk patient, you have to be very careful in these patients that vitals should be monitored regularly. And minimum time is which I prefer. Every half an hour, blood pressure, temperature, pulse, and bleeding should be carefully monitored. This and in another case, there was a normal delivery. Primary gravida, gestation is 37 weeks. Prolonged labor, the patient came. She was having pains for, I think, more than 24 hours. Trial giving elsewhere, but she presented with crowning of head. So I cannot, I don't have, I wasn't having so much time that I can shift it to this patient to OT. And the episiotomy was given. The patient was delivered because the fetal heart rate was all okay, 150 per minute, regular. Episiotomy was given, delivered a female baby weighing around 3.205 kg. I was expecting PPS, so I gave carbetocin as a first line of drug. Slow IV, placenta delivered easily. Uterus was well contracted, bleeding was normal. Patient was up to the 2 hours. Next, please. And in cesarean section, in the high risk patient, I normally prefer this drug. Reason being, patient cannot give you second chance to reopen to do reopen or for laparotomy. Women, ABC, G2P1L1 with previous LSCS, with placenta previa, bleeding was excessive. Carbetocin was injected, patient stopped bleeding, and no PPS was observed. But in this case, I remember as the patient was having low lying placenta previa, I stitched the bed also. I gave the stitches, the posterior surface of the uterus also, plus Trenexa 1 gram prior to the surgery. So, and followed by after delivery of the baby, I gave this carbetocin. So the patient was not having any PPH. This was my observation. Thank you so much for patience hearing. Now will have panel questions.
Madam, thank you, Marriage. It was wonderful, hearing your insights on this. Is exactly what the doctors want, our own doctors' experience. This will give them a lot of confidence to use carbetocin. Like you said, the patient when you use her head was almost crowned before
Yeah.
taking to theater. I mean, these are some of the things which are very important. But overall, how is your experience about carbetocin in terms of efficacy, adverse effects?
Yes, doctor. Actually, I have in few cases.
Yes,
My first line of treatment is carbetocin.
correct.
Whenever I expect that this patient is going to bleed,
Mhm.
or there is any past history of PPH,
Mhm.
or there is any, or the patient is having twin pregnancy or over distended of uterus, whatever the cause may be, like fibroid and
Correct.
twin, triplet, polyhydramnios, whatever the reason may be. In these cases, my first choice is carbetocin, and really it gives result. You can see the I don't have
Yes,
video.
yes,
You can see the globular fundus
correct.
clinically also,
Mhm.
and very hard football like, and the bleeding amount of bleeding is very less.
And generally use IV,
Yeah, I use IV, slow IV,
slow IV.
to be given slowly, and I prefer intramuscular also, where
Correct.
in which I expect okay, this is okay type patient, this won't go into the PPH.
Maybe where you want a little longer duration of effect.
Yeah, little longer. Yes,
Correct.
exactly,
Correct.
exactly.
The patient profile, I mean, most of the questions, madam, you already answered. The patient profile is one who are most likely to get a atonic uterus, I suppose.
Yes, as we have discussed,
Yes.
high risk patient.
Mhm.
Is there any history, previous history of PPH?
Correct, correct, correct,
Elderly
correct,
primer,
correct,
some
correct.
medical disorders also. So we
correct.
anticipate that
Da-
this patient can pass into the PPH. We prefer carbetocin, and sometimes, no doubt, not in all cases, but combination of oxytocin and
yes,
misoprostol in some other cases. This depends upon the patient condition also.
absolutely. That's correct. And diabetic patient are more likely to get PPH or not, like nothing like that.
Yes, diabetic patient. I have came across around 2 3 patients in
Uh,
which definitely that the patient had PPH. Reason being the premature rupture of membrane
oh,
and the infections also.
correct, correct, correct.
Chorioamnionitis is also a cause which causes PPH in diabetic patient, because
Correct.
they are infected. UTI is very common in these patients. That is
Correct.
why.
Correct. The cause per se may not be diabetes, but the other associated factors could lead to PPH.
Yes. If there
Yes,
are any
correct.
medical disorder,
Correct, correct, correct,
I
correct.
definitely prefer. I don't want to take chance in such
Yes,
patients.
finally life is at stake now. I mean, why
Yeah,
should we? Yeah,
yeah,
correct. Very
definitely,
correct. Very true.
definitely, doctor.
I mean, you have already answered this. When you prefer carbetocin, I don't want to waste your time again. It's the same question.
Yeah. What is your
Yes.
experience, Doctor Prashant?
I mean, whatever experience that I have heard, that people these days, as you rightly said, they don't wait for, I mean, especially in private settings, they don't
Yes,
wait for I mean, it's better you to use the best one, whatever possible today.
yes,
When I went during my, I mean, earlier days, when I was in JJ Hospital, we had
hmm,
only oxytocin and methadone. And
yes.
PPH, my God, what the situation could be in PPH. The entire hospital was there. Anytime we get PPH in the
But do the hospital prefer refrigeration and all this?
At that time, yes, they did have. I'm talking about the late 70s, madam. They did have. But then,
Okay.
the cold chain, transport cold chain, वगैरह is an issue. And even if you
Yes.
have a refrigerator in places like Mumbai also, there are a lot of
Hmm,
power outage in and out. So you don't know
yes.
what, I mean, finally the efficacy. And at the end of the day, it's life is at stake. I mean, if
Yes,
otherwise,
definitely,
that's
doctor.
okay. Yeah.
Have you ever tried symptometrin?
Uh, no, madam. Madam, honestly,
You
I'm not a gynecologist. Huh? I'm not a
okay?
gynecologist. Yes,
Okay.
I'm from the pharma line. I'm from the pharmacology
Okay.
line. Yeah, yeah. I'm sharing my experiences
Then
during my gynecology postings.
the gynecologist, they have previously used
Symptomatic,
cyanometry.
I don't have in the webinar that I've done. I have not heard many doctors using cyanometry.
Okay.
I have not heard.
Hmm.
And any experience you have got your own experience in retained placenta?
Yes, retained placenta, yes, maybe. But prior to the retained placenta, we have to definitely, yes, it is useful in retained placenta also. but we have to rule out any hematoma inside hematoma
Correct,
or
correct,
internal
correct,
bleeding also,
correct,
intraperitoneal bleeding also.
correct.
So we
And
can
maybe you have
use,
to, yes, you have to remove the placenta also with the retained.
yes, yes.
There are RH negative mothers, I suppose there
Yes,
should not,
yes.
yeah.
This can be used in RH negative mothers also.
I
No
suppose, you know,
problem.
anytime they get bleeding and blood transfusions required, you know, I mean, especially in the periphery, it could be a big issue.
Yes.
Getting, yes. Can a doctor use carbetocin for prevention of PPH if oxytocin used for induction?
Yes, definitely, because
In fact,
for
that's,
induction,
yes.
yes, because normally the dose for induction is 2.5 international
Hmm,
unit.
hmm, hmm, hmm.
So we don't give so much of oxytocin, we can use carbetocin.
Yes. And I suppose our textbooks also recommend oxytocin for induction and for, you know, augmentation.
Yes.
In which cases you would prefer IV or IV? Many doctors, you know, were asking. I mean,
Yeah.
our answer was, yeah, general,
In
like,
high
you know, good
risk
durations.
patient, when
Yes.
the, yes, doctor, in high risk patient, and when a patient is having intractable PPH.
Oh, okay.
Intractable PPH, in such cases, we don't waste time, we give
Straight
IV.
away.
Yeah.
And
And
what
it is really effective. And it is no doubt, it is really
the madam, what is your opinion about a pre-filled syringe of carbetocin?
repeated use of,
No, no, pre-filled syringe.
pardon,
A pre-filled syringe of carbetocin.
I couldn't get
Pre-filled.
you.
No, no, pre-filled
Prefilled.
syringe. Huh.
Yeah. If you if a company
Yes,
makes this, and it's really useful.
exactly.
Why?
Because
Because there is no wastage of time. You are using prefilled, and you have to just giving in one shot.
and it is, I mean, every seconds matter in these type of cases.
Yes.
Withdrawing. Sometimes
Withdraw.
there could be spillage by the nursing staff.
Yeah.
So yeah,
Definitely.
that's also possible.
Yes, very
If
true. And
yeah,
what happens when you suck out from the vial?
correct.
Some drugs still
Absolutely.
remain.
Yes, 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 yes.
Yeah. And what
Eh,
happens? Normally, what do you do? The doctor normally don't give
no,
IV.
no, no, no,
But
no.
any
Yes,
assistant or some
correct,
staff is going to give this drug.
correct, correct,
So
correct.
what happens? I have noticed
Yes.
this is the very important. If you are giving this in pre-filled syringe, the drug
Uh,
will not be wasted.
exactly, exactly. The entire drug would be used. A, the time would be short, and B, the entire drug could be used.
Yes.
If the patient is not responding with carbetocin, what additional uterus? I suppose everything and anything that we have. Yes.
Although the carbetocin is really
Yeah.
effective, no doubt about it. And the second drug, I normally not utrotonics, I give Trenexa.
10x absurd. Yes.
Yeah, Trenexa 1 gram.
Correct.
1 grams slow IV. You give to start with, you give 500 grams slowly IV, then wait for another half an hour or 15 minutes, and it works. This combination works.
Yes.
I don't
Even
normally, yes.
even in the recent AICOG meeting, which was in Bandra, Mumbai, many doctors who spoke on PPS, they did say carbetocin and of course tranexamic acid. You know, they did mention
Yeah.
a benefit of tranexamic acid.
And sometimes you can use carbetocin plus ergometry, methyl ergometry,
Argometer. Yeah, correct.
intramuscular. Yes.
Correct. You've already taken this, madam. Madam,
So
have you seen ADS type of water retention type of adverse effect with
when
oxytocin?
no, I have not seen or ADH in while using
Oxytocin, yeah.
carbetocin, but
No,
in
no, oxytocin,
oxytocin,
yes.
when we use higher dose,
Higher dose. Correct.
then find these findings.
Yes, many doctors did say this, you know, higher dose
Yeah.
or if you use a prolonged period, you can get it.
Yes,
And
definitely.
methyl ergometin related hypertension.
Methyl ergometin, what happens where if the patient is having any cardiac disorder, or
Hmm,
either or and if for God's sake, if she is not having any cardiac disease, is still in some patient, we have noticed that the patient is having arrhythmia,
correct.
and which is very problematic while you are doing cesarean section
Hmm,
or you
hmm,
are
hmm,
doing
hmm.
normal delivery. So normally we avoid this.
Avoid, yes, yes, yes.
uh,
And when better options are available, why go
yes,
for
yes,
adverse?
when
Yes,
better
yes.
options are available, why not go for
Correct,
that?
correct. Should carbetocin be kept as a reserve drug? No more it is kept as a reserve drug, of course. Maybe in,
No.
yes,
Not at all. Not at
not
all.
at
It
all.
should be first line drug
First line.
in PPS, intractable PPS. It should be first line drug.
How would you compare adverse effects? Principally over oxytocin. I mean, oxytocin adverse effects. Have you seen any adverse effect with oxytocin, basically?
Yeah, definitely. What happens in oxytocin?
Oh.
Number one, it has to be kept in refrigeration,
Yeah,
the
yeah,
2
yeah,
degree,
yeah.
degree centigrade, centigrade. And what happens when you give when a patient is having PPH, sometimes you have to give IV also, but you
Correct.
have to be very careful. Reason being, there is sudden fall in
Oh,
blood pressure,
yes.
and
Hemodynamic.
then the rebound tachycardia occurs, and the sudden peripheral resistance decrease in sudden peripheral resistance also, which can lead to again fall in blood pressure,
Correct,
and
correct.
leads to tachycardia. So and in some cases I have read it increases nitric oxide.
Oh,
So when oxytocin increases nitric oxide, it leads to
blood
again.
pressure drop.
Yes.
Correct. Blood pressure.
So close monitoring is needed. Like
Yes.
tachycardia, you have to keep the patient in ICU or in
Hmm.
post-operative.
And
Then
continuous
also,
nursing, yeah, nursing staff should be there, especially peripheral. This
yes,
could be an
nursing
issue.
staff.
Yes.
You have to also keep watching and keep
Yes.
monitoring, because we are sitting in the rural,
Absolutely.
so we can't take chance.
Your one line, your opinion to the audience about carbetocin.
Yes, pardon. How would you?
Conclude. Your just one
Yes,
line about,
conclusion.
yes, conclusion for the audience.
Yes, definitely. My opinion about carbetocin is because its onset is very fast, within 1 to 2 minutes. Number one, and it lasts for a longer period.
Correct.
The uterus is contracted for a very long period, like 1 hour or 1.5 hours. Number one. Number two, it has less side effect. Like in carboprost is also very dependable drug, but carboprost, the patient can have vomiting, diarrhea,
Yeah.
the field become messy,
Messy, it
because,
will be messy, correct.
and the patient can have a cardiac problem also, like bronchospasm.
Hmm.
So, as far as efficacy, safety, and tolerability of the carbetocin, this is better and superior drug.
Madam, thank you so much. It was really wonderful, hearing to your opinion on carbetocin. It gives me a lot of insights about the drug. And I'm sure the doctors must have got confidence about using the drug. And thanks once again, madam.
Thank you so
Thank you.
much. So nice of
Yes.
you. Thank you for the
Thank
patience.
you. Yes. Thank you, all the doctors who took time from the schedule and attended this webinar. Thanks, marketing and sales team of Hitro for conceptualizing and coordinating. And thank you, IT team Hitro for IT-related help. Thanks, all of you. Madam, we can sign off. Thank
Thank you.
you. Wish you a very good evening. Thank you.
Thank you. Okay.
Thanks, Ravali. Thanks, Priyanka.